So we're going to start this by actually looking at a quick little anatomy and physiology review for the immune system. And the concepts for the immune system are found in chapter 16, and they go over basic things like the inflammatory process in the immunity system, and that's just looking at like how the body, when a virus is introduced, you have different, immune responses that come into play, whether it be inflammation, or when that antigen comes in, it creates antibodies, it finds a way to destroy the virus. And then you even have like little memory cells that help to recognize if that same antigen would be introduced again to the body. It recognizes it and it kind of quickens up the response. So normally once you're sick with one thing, that's why you don't get sick with the second one, because even though you've been exposed, your immune system's already prepared to fight and it kills it off before you actually start having symptoms. Two things that I really want to focus in, especially because a lot of this content lectures over HIV and AIDS are the CD4 T lymphocytes, or the CD4 cells. These are the ones that help to coordinate the immune response by stimulating other immune cells in your body, such as the macrophages, which I kind of think of them as like the little Pac-Mans of the immune system. They're the ones that come along and kind of gobble up stuff. You have your B lymphocytes and your CD8 T lymphocytes, which also help to fight off infection. They're often referred to, the CD4, I should say, are referred to as the CD4 cells. Sometimes they're called T helper cells or just T4 cells. Those words can be used interchangeably sometimes when you're listening to lectures, so just know that it has many different names that it goes by. And its main function is to send signals to other cells of the immune system that include the CD8, or those killer cells, or those killer T cells, which then destroy the infectious particles. So this is just some statistical kind of information as it pertains to the AIDS virus itself. It is the most common immune deficiency disease in the world, and you need to think of that worldwide. It's not just something that happens in the United States. It is considered a serious worldwide epidemic according to the World Health Organization, or WHO. About 37.9 million people are currently infected with the HIV virus or have already converted over to the AIDS. Most new infections reported in the U.S. are coming from some of our racial and ethnic minority groups, such as African Americans or Hispanics. And another group that has an increasing incidence right now is the transgender community, especially transgender women. They're seeing a lot of rise in that particular area of the population. This is a picture. I'm very visual. I like to look at pictures when I'm learning. So this is just showing you a healthy CD4 cell at the top, and it has these little receptors that are on them, these CD4 receptors, or these CCR5 or the CXCR4 co-receptor. Those are the receptors that the HIV virus actually is drawn to, and that's how it attaches to the CD4 site, or the CD4 cell, and that's how it begins that process of introducing itself into the actual cell itself. So now we're going to take a quick little look at the life cycle of HIV and how it actually goes into the cell, replicates itself, and then makes new or more of themselves. So you can see here the virus comes in. If you're looking over to the left, it goes in, comes through the cell, like I say, by attaching to those receptors that were on the previous slide. And then once in this fusion, kind of look where it's going in, and it's kind of important to understand this because this is where the medications work. So if you're looking at these fusion inhibitors, it kind of tries to stop it from actually entering the cell. Once inside the cell, it uses this reverse transcriptase that the virus has to convert over to DNA. So it's kind of a cool thing about HIV because it is a retrovirus. It actually finds a way to link itself to the cell's own DNA and kind of take over the cell by doing that, because it kind of impregnates itself into what was our normal DNA and kind of becomes part of this cell's now new DNA. And so then because of the integrase, it pulls it into the center, or into the nucleus, and that's where it goes through the replication process again, and eventually it comes out because of the protease. It pulls it out, and then the protease helps also to make the new cells. So this is kind of how the life cycle, or how HIV goes from just being a virus outside the body that the person is infected with, finding those receptors to attach itself to, working its way into the cell, combining with their own person's DNA by this reverse transcriptase RNA, starting this conversion. And so it basically takes over a healthy cell and turns it into a new viral cell. So this is just kind of the process of how it works. And like I say, it's kind of nice to see these because if you look down at here at the bottom, you can see fusion, reverse transcriptase, integrase, and protease. When you look at the medications, they all affect that one, one of these areas and how they stop the virus from replicating and spreading. Now, just looking at HIV progression, this disease can take months to years to progress to somebody converting from HIV positive status to actual AIDS diagnosis. Personal life factors can definitely affect the timing and progression, and I think about this too when you think of a lot of different disease processes. Cancer is one of those where, you know, different things can affect how rapidly the body changes and can become overwhelmed by whether it be cancer or this particular virus. So frequency of re-exposure to HIV. So if I'm thinking like if you have an HIV positive partner and you're engaging in sexual activities with somebody without any kind of protection, the more exposure you have, the higher the risk, of course, is going to be that you're going to have more and more HIV exposure, and can also help the virus progress more rapidly. Presence of other sexually transmitted infections is also something that can affect the timing of the progression. Nutritional status, that kind of makes sense. If the person is not well nourished, they can't fight off infections as well, so that will also affect it. And stress, really, when I think of stress, we think of stress as just being like mental, you got to calm down, but stress really wreaks all kinds of havoc on the body, and especially with the immune system, it's one thing that can definitely weaken it, make it less effective. And so if that person is really stressed out and that immune system is weaker, this can definitely progress quicker on that particular person. And exposure from blood transfusions will definitely result in a quicker development of the disease versus somebody who has been exposed to it through like sexual contact. Effects of having HIV or the HIV infection. So the CD4 T cells themselves become little HIV factories. And when we think about what we just talked about on that one slide with the picture, it makes sense. Instead of doing what they're supposed to do, being a CD4 cell, which is to help recognize what's supposed to be there and what's not supposed to be there, they turn into little HIV factories instead of doing their job. So gradually that CD4 T cell count starts to fall as that viral load rises. So it kind of works on kind of like a teeter-totter thing. One goes up, one goes down. It definitely weakens the immune system. So then these people become very prone to opportunistic type infections. Something that's important to note is everybody that has AIDS has HIV, okay? But not everyone with HIV has AIDS. Especially, I think, today's day and age with some of the medications we have, there are many people who are HIV positive that do not convert over to actually having AIDS, which is that acquired immune deficiency syndrome. That's what AIDS actually stands for. So remember that your CD4 T cells have recognized, I just kind of said this, self versus non-self. Thus they call to arms those different white blood cells that are responsible for those inflammatory response, which helps with infection. When the immune system has been assaulted, it also helps to create antibodies and also cellular protective actions. Right here is, now that I'm looking at, is really kind of a word slide of what the picture slide that I showed you earlier just shows you how the HIV virus will enter that CD4 cell through those receptors or co-receptors of that CD4 T lymphocyte. Once it gets inside, it injects itself into the RNA of the cell, okay? It uses that reverse transcriptase enzyme to create a single strand of viral DNA versus normal healthy DNA. It then creates a second strand of viral DNA to create a double-stranded viral DNA. So basically, it's creating its own double-stranded viral DNA instead of it being the DNA of the normal cell. That integrase is the one that actually grabs hold of that viral DNA and re-enters the T cell nucleus and then helps it to become part of our DNA. So it creates the DNA outside, not the nucleus, but within the cell. And then once it's ready, that integrase grabs it and pulls it into the actual center of the cell, so then it can become a part of our DNA. And this is just a slide just kind of showing you that the CD4 T cell and the viral load kind of work on this teeter-totter effect. So as those CD4 T cells go down, the viral load in the person goes up, which is something you definitely don't want to see. And this is why they typically tend to check the CD4 T cell count on a regular basis, is to see where they are in that process. This slide here is just looking at the different classifications of HIV, and this is really based a lot on your CD4 count as well as whether there are any AIDS-defining illnesses going on. And this is in your book. There's a table 17.1 on page 325, and there's also another table in your ATI book on 571 that kind of looks at this. So this class 0 defining features, this is where the patient has already been diagnosed. So we do know that they are positive, but the CD4 is usually in a normal range. And a normal range is 800 to 1,000. So their CD4 count still looks in a normal range, and we have no AIDS-defining illnesses at this time. Class 1, the CD4 count is usually greater than 500, but still lower than that normal range of 800 to 1,000. And they also have no AIDS-defining characteristics. Class 2, your CD4 count usually is between 200 and 499, and there are still no AIDS-defining illnesses present in this particular person. And then when we get to class 3, the defining features of that is that that CD4 count has dropped below 200, and any patient, regardless of the CD4 count, who has AIDS-defining illnesses is given that AIDS actual diagnosis. So now we're going to look on this next slide of when I'm saying no AIDS defining illnesses, what are some of those illnesses that are considered AIDS defining? Here are some of the AIDS defining conditions that we talked about on that previous slide. These are just some of them that I've listed. There is a table in IGGI on page 326, this table 17.2, that lists the whole gamut of them. The first one is Kaposi sarcoma. That is, actually it's a type of cancer. We don't see it in typically normal healthy people that have a functioning immune system, but it does affect the skin, so they look like they have little wounds all over them. Large B-cell non-Hodgkin's lymphoma or Burkitt's lymphoma are something that they're prone to. They can develop candidiasis, and we think of this as kind of like thrush of the mouth, but this can also go into the bronchi, the trachea, the lungs, as well as the esophagus in these patients. They can develop different mycobacterium type infections. So that's taking you back to your microbiology days. Recurrent infections, I should say recurrent pneumonias in particular. So if they're diagnosed with more than 2 bouts of recurrent pneumonia within a 12-month period, that may be considered an AIDS-defining illness as well. Toxoplasmosis of the brain or toxoplasmosis encephalopathy. Histoplasmosis. And this is something that you can get from, they're basically fungal spores that can come from bird and bat droppings. So they're generally inhaled. And then also wasting syndrome attributed to HIV. So these are the patients that look very cachectic or incredibly thin and very gaunt in their appearance because they're just basically wasting away. Okay, and these are just a couple of the different AIDS defining conditions that I kind of talked about on the other page. This first one is the Kaposi sarcoma. So you can see he's got all these little spots and little scab looking areas all over his body. So that's what it looks like. I would tell you to be familiar with Kaposi sarcoma. If you see that term, generally in testing, they're kind of trying to draw you to the fact that this patient has AIDS. So that's one of those things, if it's going to pop out at you, that's something that I would tell you to be familiar, that people with AIDS develop Kaposi sarcoma. And then also this other picture is someone who has this candidiasis, and this one's in the mouth, so this is like a thrush in the mouth kind of thing. But these sores or this fungal infection can go all the way down, like I said, the esophagus, the trachea, into the bronchi and the lungs itself. So just some pictures of actual some more AIDS defining conditions. The first one is, you can see, and this is in a young child, Burkitt's lymphoma, affecting probably the cervical mandibular type lymph node chain there with this Burkitt's. And then the other picture is showing that wasting syndrome. So you kind of get a look to see what that patient actually presents like. And you can see that they are very thin, very cachectic in appearance. So some other important things to know health promotion and maintenance wise is HIV is usually transmitted via these routes. It's through blood, body fluids, and mucous membranes. So how that happens is through sexual contact, which most people are probably familiar with that one in particularly, parenterally, so this is like through contaminated needles, stuff like that, and also perinatally, so this can be passed from mother to baby. HIV is not transmitted through casual contact. So sitting down with somebody who has HIV, you are not going to get HIV. If you touch them, if you shake their hand, if you hug them, okay, you cannot get HIV transmitted that way. You don't get it by sharing household utensils, towels, linens, toilets. So they don't need their own bathroom. It is also not transmitted via mosquitoes or insects. And you know, I'm a lot older, and I remember when HIV first kind of came on the scene back in the early 80s, and there were a lot of rumors going around. And yes, one of them is that, oh my gosh, if you get bit by a mosquito, you might get HIV because that mosquito might have bitten somebody who had HIV and they can transmit it to you. And that is not true. So if you ever hear that, that is a falsehood. You also are not going to get it through casual contact. And I often think of Princess Diana. One of the things that she was very well known for is when HIV was first really coming to the forefront and people were getting diagnosed with it. She made a point, she was very well educated on this, and she made a point to go into HIV wards in the hospitals over in Britain as well as other countries that were within the monarchy. And she would sit down and talk with patients, and she would hold their hands and she would hug them to try to distill some of this fear that was going on at the time. And so she did a lot of good things to help people understand the transmission of HIV. The higher the viral load, the more likely the person is to spread the virus, which makes sense. So when we start looking at where people are in those stagings of HIV, the person with the highest viral load is going to be the one who is going to spread the most. And unfortunately, you're highest in the first 4 to 6 weeks of being infected. And the sad thing about that is sometimes you may not feel well, but it's very flu-like in the beginning, so you just think you have some kind of other viral infection. You may not be aware that you are even HIV positive when you are at the highest risk of giving it to somebody else. So it's just something to keep in mind that the highest risk is actually in that first 4 to 6 weeks after infection, and that's because the virus is really replicating itself fast and furious. And if you think about most viral infections, that's kind of the case. Most people are infectious before they even know they're sick, so they've already spread it to people. The flu is that way, colds are that way. So just something to keep in mind. Now we're going to look at each one of these modes of transmission individually, just really briefly. Sexual transmission, like I said, this is one most people are probably the most familiar with. Risk of exposure due to body fluids, blood, and mucous membranes. So you all have all three things going on there. The CDC describes ABCs of safer sex, meaning abstinence, be faithful, and use condoms. Okay, that's what the ABC stands for. It is most commonly transmitted through vaginal sex, okay, or intercourse, but the riskiest form of sexual behavior is anal intercourse, just due to the possible tears in the mucous membranes and also the possibility that when those tear, that may allow there to be exposure to blood. And so that is why that is the riskiest behavior, but the most common way is through vaginal intercourse. We're going to look at the second form of transmission of this parenteral, which you guys should be familiar with this term because we talked about parenteral nutrition and stuff back in third semester, which is basically meaning, through the blood kind of thing. So this one is mainly transmitted through sharing of needles, and you see this sometimes, unfortunately, with people who have substance abuse problems, and they're using needles to like shoot heroin, stuff like that. So one of the things they talk about is proper cleaning of the works, so to speak. So the needles and syringes, other drug paraphernalia, they want them to use water and bleach to clean the needles. And there's also something called the needle exchange programs, and sometimes you'll see this more likely in your bigger cities than in like a small rural area, where people who have drug addiction from injection like this, there's actually places they can go, they can put their needles, they can get clean needles to inject. And I know that seems a little counterproductive, but it's a way to help stop the spread of HIV among addicts, because unfortunately when they're desperate and they will do anything they can to get that fixed. So it's just a way of trying to keep them safer, and in the end also keeps general population safer if we don't have as much HIV being spread out there. Blood transfusions is a way that you can get HIV. The risk now is very, very, very low. It is still possible, but the screening is so much better now than what it used to be when HIV first came on the scene, that it's still there, but it's very negligible, the risk to actually receive a blood transfusion. And then also you can also do an autologous transfusion, meaning that you would bank your own blood. So if you were having a surgery where you knew that there was potential that you could have blood loss, they would actually do blood take your blood, and then when the time came, they would give you your own blood back. And oftentimes when they do that, because red blood cells only have a shelf life of 120 days, and maybe they need multiple units for you, what they typically do is they will give you some kind of growth factor like the adipoetin alpha that we've talked about in the past, to help speed up that process so you make more red cells quicker so that they can get the blood they need for the estimated blood loss that they may think you're going to have from surgery. Okay, and the final mode of transmission is this perinatal, where it goes from mother to baby. This can occur across the placenta during pregnancy. It can also happen at birth when the baby is exposed to blood and vaginal secretions. That's why they tend to do C-sections with these children. And also exposure after birth through breast milk. So if a woman is HIV positive, they are discouraged from breastfeeding their children. Transmission rates have dropped, though, from 25% to about 8% with the use of antiretroviral medications, or I should say retroviral medications. Therefore, we do encourage women who are HIV positive and pregnant to continue with their therapy. There are some medications, if you go think back to Megan's lecture, she kind of talked that they had a wide range of where they were on that pregnancy risk with the medications. They would just switch to something that was safe during pregnancy, but the mother needs to be, made aware, educated that yes, these medications are safe for you to take during pregnancy. In fact, it's much safer for you to be on these medications than it is to run the risk that you could spread, or share HIV with your unborn child. So good education for mothers who are HIV positive. We're going to look real quick at transmission to healthcare workers. Needle sticks is definitely the number one way that healthcare workers are exposed to HIV. So exposure of non-intact skin through mucous membranes or through blood and body fluids. Standard precautions is the best prevention. This is something I want you to put to memory too, because I have seen questions on this when I'm, being in my nerd self and just doing questions because I feel like I'm bored and I need something to do. This is something that I have seen come up multiple times, is they want you to understand that when somebody is HIV positive, they are not in contact precautions, they are not in airborne precautions or droplet precautions. It is standard precautions. The only time you would see any of those other precautions used is if the patient has something else going on that puts them there. Like sometimes these patients can be prone to mycobacterium bacteria, and one of the first ones I think of is tuberculosis, because that's what it is a mycobacteria. And so if the patient is AIDS positive and has, TB, they would also then not only be in standard precautions, but now we're going to have to add airborne because the patient has developed another condition. But just for somebody who is HIV positive, who does not have any other need for requiring any of these other types of precautions, they are strictly standard precautions. Okay. Recommendations for preventing HIV transmission by healthcare workers. This can be found in IGGI, and I want to say there's a little box, but I don't honestly remember. I found it. It's on page 330 in your IGGI book. And post-exposure prophylaxis. Again, this is in your IGGI book. This usually uses a current combination of antiretroviral therapy for 28 days or until the HIV status has been determined as negative. So if you were to get stuck by a sharp and you did not know the HIV status of the patient, they would put you on these antiretroviral therapies for at least 28 days or until the status can be determined. Okay. Best results occur if you start within 2 hours of exposure. And that's why it's so important, if you have an exposure, that you report that exposure so they can begin that process to get those medications started for you. Okay. And also, if you were to stick yourself with a needle, it's important that you wash that area for at least 1 full minute to flush anything that could be in there. That also is another way to help decrease the ability of that to transmit. We're going to move on from transmission to how we manage the disease. So some collaborative management things, and again, you can see there are 12 pages of management of the client. So these are just the high points. Assessment-wise, you want to monitor them routinely to assess that immune function. How well is that immune system working? May range from every 2 to 6 months. So depending on probably what that CD4 count is doing and how the patient is doing, you'll see them every 2 to 6 months to assess that immune system function. You always want to get a good history. Ask about how old they are, what's their gender, what do they do for a living, and where the client lives. And that is important. Do they live in their own home or are they on the streets? Because that does make a difference in the level of stress they're going to be under. It's going to change like their nutritional status, all those things that go into the potential that this virus may progress more rapidly. Always assess the current illness. Determine when the client was first diagnosed with HIV and what manifestations or signs and symptoms led to them being diagnosed. Determine if the client had a blood transfusion between 78 and 85, because that is when the most tainted blood was given to patients. And then we became aware that, oh man, now we have patients getting this through not just sexually transmitted reasons, but also through blood transfusions. It was really sad because when HIV started, the population that it was most seen in was homosexual males in particular. And, there was a lot of judgment going around that this was a disease brought on them because of their behaviors from society. It was just not well received. I think back to those days and it just kind of makes me sick how people treated other people. But that was the thought. And then people started getting it through blood transfusions, and some of them were even children who had like hemophilia and had to get blood products. And then it's kind of like there was a change in tone when that all started happening. And it was sad that it took, for that to occur before people really wanted to start taking HIV more seriously. Because it was now affecting, children and not people who they thought were engaging in bad behavior. So it was really a very sad, judgmental time in history when I think about how HIV started. And I'm glad that we've definitely turned the page on that and, found more common ground. So I'm happy about that. You do want to ask them about their sexual practices, and not because you're trying to be nosy, but really you're just trying to determine the risk for them as well as for their partners. If they've had any other sexually transmitted infections or other major infectious diseases, you do want to ask them about possible drug use because they may still be using, and you want to make sure if they are, they're using clean needles and not sharing their needles with others. And then determine their knowledge regarding safe sex practices, because some people don't know. They just don't. They don't think about it. So sometimes that's our job as the educator, as the nurse. Okay, so when you're doing the physical assessment and you're looking at these clinical manifestations, you always want to assess for, what other body systems are being affected. So we always associate HIV with infections. So we're always looking for those opportunistic type infections, whether they be from fungus, bacteria, viruses, or protozoa. You also want to assess for the risk of malignancy because we know Kaposi sarcoma and some of those lymphomas like that B cell or that Burkitt's lymphoma is something that we see, and that is one of those quote AIDS-defining illnesses, as well as other invasive cancers and HPV. They can develop endocrine complications, gonadal dysfunction. They can have adrenal insufficiencies. They may develop diabetes, and also they can have cholesterol and triglycerides can be affected, so they may be elevated, which definitely puts them more at risk for cardiovascular complications. As you can see down here, it talks about that results from both the disease and from the medications. Metabolism may change, and diabetes also add to the risk of hypertension and atherosclerosis, which kind of makes sense if I've got endocrine problems managing diabetes, as well as if I have increased cholesterol and triglycerides, those fats. Those are two things that lend people to the development of cardiovascular disease. And so cardiovascular complications are now the leading cause of death for a person living with HIV. So, back in the day, it was more they died from these opportunistic infections because the infections just could not be controlled. But now with some of the medications, we're able to kind of keep that at bay. So now we're seeing more people dying from cardiovascular complications today. Can't forget about psychosocial assessment. It's great that we do all the physical assessment because those things are important, but we also need to take into psychosocial considerations as well with these patients. So ask them who their support system is. Keep in mind, this is a very scary diagnosis for many people. They instantly, for a lot of people, they associate HIV with death. Even though, like I said before, management of disease is something that now, to me, for some people, it will mean end of life, but for a lot of people, I think of this as like a chronic condition now that will just require them to be on medications and manage the disease for the rest of their life. So asking them about their support system, who do they have that they can count on? I also think about assessing, are they at risk for harming themselves if they get this diagnosis, or if they find out they've had this diagnosis and they find out their partner, they're like, did I spread this to my partner, kind of thing. So always make sure you're doing a good psychosocial assessment with people who have HIV, and also determine who is aware of the diagnosis to protect the client's privacy. So this is definitely not something you go blurting out in the hall, by the way, your patient is HIV positive when you're giving a report. You want to do that more privately because, like I say, this is a disease that really evokes fear in people, and so we want to be respectful of that. Things that you can see with your HIV patients or AIDS is this AIDS dementia complex. This does occur in about 70% of patients who convert to AIDS, not HIV, AIDS. So make sure you keep that straight, okay? It does cause cognitive, motor, and behavioral impairment, so it's a form of dementia. So you've learned about dementia, or I think you may have in mental health already. May also affect peripheral neuropathy. So these patients may also complain of numbness, tingling, burning. Sometimes they'll have trouble with movement in the arms and in the legs or hands or feet. So those are all things that can happen with AIDS. Like I say, these are AIDS. Understand, it says AIDS, not HIV. That AIDS wasting syndrome, that's one of those AIDS-defining illnesses, and kind of already talked about. This is where the metabolism gets altered, and this is often associated with the cancers that they might develop or with infection processes that they're having. So they become very thin, very cachectic. They may have diarrhea. They have a hard time absorbing what they do eat to get the nutrients that they need. They may just not feel like eating at all. Keep in mind they may also have that candidiasis that goes down the mouth. It may go down into the esophagus as well as the trachea and all those other places. So they may have lesions that can definitely affect weight loss, because when you have those, number one, food doesn't taste good when you have that stuff in your mouth, and it's also very painful to eat. So this becomes a big problem for them. They may also have some changes to their skin, so you can see dry, itchy, irritated places. They may develop rashes. They can also have issues with blood counts. So it talks here about observed for petechiae and bleeding gums, which if I were in class, I would ask you, which would tell me what, and your answer should be that your platelets have probably dropped in this patient. So that's something you want to definitely observe to make sure they're not at risk for bleeding. Last little thing I'm going to talk about as far as clinical manifestations are concerned are that this virus can definitely or can affect renal function. So these patients may suffer an acute injury from an event. Think if they get really sick, they might develop something like sepsis, which then could lead to a drop of blood pressure, which can affect the kidneys in the acute process. They could have several of these, or they over time, because of medications and stresses on the body, they can convert to a chronic kidney type disease too. So the HIV patient population has a 16-fold higher risk of requiring renal replacement therapy. So people with HIV are 16 times more likely to have some kind of dialysis, be that hemodialysis or some kind of peritoneal dialysis. But like I say, keep in mind, you start thinking about the blood, it gets kind of scary, but they are going to require something to do the function of the kidneys because the kidneys are no longer able to do that for them. Okay, so now we're going to switch gears and talk a little bit about some of the lab that they use in patients with HIV or to find HIV. They will do like a CBC because they will look at that lymphocyte count. Typically, patients who have HIV, they will be leukopenic or that lymphocyte count will be down. They'll also look at the CD4 and the CD8 T cell count. Normally, the ratio is about 2 to 1, so you have twice as many CD4s as CD8s. In HIV, this ratio is lower, and the lower ratio is associated with disease manifestations. And then we look at things like antibody testing, and these are things you should be familiar because you should have discussed this in third semester. So if they suspect this, they may do an ELISA test, which is an inexpensive test. It's usually very accurate, but they can have false negatives if the antibodies are not yet present. So it may be something that they may need to have it done, but they may need to repeat it, especially if they feel like the patient may in fact be HIV positive. And then if they get a positive on the ELISA, they will do this Western blot test. Okay, so that's just something to know that ELISA is usually the first. Western blot is the one that's actually used to confirm. Again, going back to questions, I've seen questions like this where they want to know which test confirms. If you see Western blot on that, that is your answer for that type of question. And some of the newer CDC recommended testing, and this is, they have a 4th generation HIV assay test that they do that will detect this HIV IgM and IgG that will be positive in 21 days, and also the presence of this P24 antigen in the serum that can show positive in 14 days. If they do this and the sample is negative, then no further testing is required. If they do this test, this 4th generation test, and it's positive, then there's a 2-step process that they'll use to differentiate between HIV-1 and HIV-2. I don't want you to get hung about this. I'm not going to ask you about this, but I just wanted you to know that there are additional newer tests other than just the ELISA and the Western blot, although in CLEX that's kind of the ones they're wanting you to focus in on. Some additional lab testing that may be done. We do actually have home tests now for people who suspect that maybe they have been exposed. These do need to be performed though at least 3 months after exposure. They may use blood, they may use like oral transmucal exudate, and a positive test. If they do these at-home tests and it turns out positive, it doesn't mean that they are, quote, HIV positive. It means that they need to have additional testing for confirmation. So just something to let people know if they're using these tests that does not necessarily mean that, yes, you have HIV, but yes, you need to come in for further testing because there is a risk or possibility that you do, in fact, have HIV. And then we have viral load testing, or something called a quantitative RNA test. I'm going to tell you, be familiar with this one as well. I have seen some questions about quantitative RNA assays or testing looking at viral load. So these just help to indicate the level of viral burden that the body has. These are used oftentimes to monitor disease progression, so how far has the disease progressed, but they're also very helpful in treatment effectiveness. because it's kind of like when I think of my chemotherapy patients, I gave one drug to them, and then I kind of sat around and, we did a couple of treatments, and then we would scan them to make sure, is their cancer responding to that therapy? And that's what this quantitative RNA assay is like. It's like they will give them a combination of antiretroviral medications, and then they will do this quantitative RNA to see if the viral load is staying low, so the burden would be low. If they're seeing that that viral load is increasing, that's telling me that the medications that the patient is currently on, they're not being as effective. And so it may be time at this point that we need to make adjustment in the medication regimen. So that's where quantitative RNA assays are very helpful. And that's probably why I've seen questions regarding this in reference to NCLEX. Some other labs that we'll do will be things like blood chemistry, so those complete metabolic panels. We'll be doing CBCs to look at how those lymphocytes, because I told you they tend to be leukopenic, so I want to make sure that they're not at super high risk for infection. They may be looking at stool testing, again, looking for fungal, protozoal, bacterial type infections, or bleeding. Biopsies if they suspect any of these cancers. Urinalysis, again, urinalysis, LFTs, hepatitis panels, lipid profiles, because we've already said that this could affect our lipid panel. But things for basic overall health, because some of these medications can affect like liver function and stuff like that. And then TB testing, because these patients are at a higher risk for development of TB versus somebody who is not HIV positive. So that may be another test that they will be doing for them. Preventing infection, or how do we prevent infections from happening or spreading to other people? I did write in here to remember to review your boxes in IGGI. Maybe I should bold that for you. Avoid crowds where people may be ill. Kind of think about anybody who's immunocompromised, whether it's from HIV, they have some kind of autoimmune disorder, if they're taking medications to suppress their immune system, they're an oncology patient who's on chemotherapy. You want them to avoid crowds. So a lot of this is going to be stuff you've already learned, okay? Hand hygiene, good hand hygiene, and I don't really care if you're HIV positive, cancer, or just generally in good health. Good hand hygiene is always important. Do not change pet litter boxes, okay? If you must, wear gloves and wash your hands immediately, because they are sensitive to some of those bacteria that live in litter boxes or fungal things. No reptiles or turtles. Again, they can lend themselves to some of the infections that these people are at risk for. Take your temperature daily and report any signs of infection to your provider. That one you should already know. We talked about that in oncology. Like I said, I want you to think about these patients like you know other patients who are immunocompromised. Take all your prescribed medications, whether that be their antiretroviral medications or if they're put on an antibiotic. They need to be making sure they're taking all their medications or things to lower cholesterol. Avoid eating foods that are raw or uncooked. Again, risk for infection. And I wrote here, check boxes in IGGI for other prevention points. So I put it at the very beginning and at the very end. So that may be something you want to review. Okay, now we're going to take some time and talk about some of the priority patient problems that can occur in patients that have HIV and or AIDS. And these can be found in your IGGI book. And we're going to talk about these each individually on the next few slides. We're looking at things like preventing infection, enhancing their gas exchange, managing their pain, enhancing their nutritional status, managing the diarrhea that they may have, restoring their skin integrity. They have the risk for being confused, reducing or they may have reduced self-esteem and potential loss of social contact. So we're going to look at those a little further on the next few slides. So we're going to look at this preventing infection. In addition to all those basic things we know about people who are immunocompromised and things we want them to do to prevent infection, we also look at the drug therapy for HIV, because we know if we can keep that viral load down, that CD4 count should stay higher, and so the patient has better prevention of infection or protection from infection. So they usually are on a combination of therapies, so HARRT, which is highly active antiretroviral therapy. Sometimes you'll see this as CART, which is combination antiretroviral therapy, or it may just be ART, antiretroviral therapy. So it gets kind of confusing to see those terms, but just know if you see HART, CART, ART, they're pretty much the same thing, kind of used interchangeably. So some of the medications that are used are some of these NRTIs, the NNRTIs, so like the nucleoside reverse transcriptase inhibitors, that's what that NRTI, and then non-nucleoside reverse transcriptase inhibitors. These PIs are these protease inhibitors, integrase inhibitors, fusion inhibitors, and entry inhibitors. And if you go back to one of those very first slides I showed you that kind of gave you that lifespan and how that cell goes about, or how that virus goes about integrating itself into the cell, these medications now make sense why they're used the way they are. Treatment with only one medication does promote drug resistance. So that's why you see these patients take multiple drug therapy or combination drug therapy, because we know that if they take more than one drug or that combination, they get much better results from their medications. It does help to reduce viral load, which I already said improves that CD4 cell count, so it slows down the progression of the disease. They are used in combinations. I kind of talked about this when we were in there with Megan. It used to be that the patient, like I said, had to take a whole handful of different drugs. Now they are in combination form, so they may have multiple medications put into one pill, so the patient doesn't have to take a whole handful, but maybe just one or two medications. But it is very important to stress to the patients the need to be compliant with their drug regimen to keep this this virus from replicating, to keep that immune system healthy, and to also decrease the likelihood that they will promote drug resistance if they are on it routinely. Unfortunately, most of these do have side effects and drug interactions. Again, with the antiretroviral medications, I've referred you back to your ATI pharmacology book in chapter 48 with page numbers there for you guys to review some of those medications. I know Iggy has a nice table. I know the homework I had you, gave you, I should say, I asked you to kind of fill in a little chart here as well. Many of these medications do interact with other medications. Most of them require that you monitor liver and renal function, which kind of makes sense. You're always going to be watching that. Several have complications, including bone loss, so they can wind up with brittle bones. They may develop pneumonia, nausea, vomiting, diarrhea, rash, flu-like symptoms, and CNS manifestations. And so again, just remember that they will be doing combination therapy. I would refer you back to the table or to this ATI Pharm book so that you're just kind of familiar. I always say when you're looking at medication, sometimes it becomes very overwhelming. When there's all these different medications you're trying to, learn about. If most of them have real common things like liver and renal, put that to memory and then pick out something in there that makes it different than the other. So, that will help you as you're studying to discern what makes this one different than the other. So maybe that's something that I may need to know. So that's just a little tip when doing medications for whether it's HIV or any other disease process. Move on to enhancing gas exchange in patients with HIV. Drug therapies, they may be on antibiotics and bronchodilators, especially if they have like any kind of pneumonia, respiratory issues going on. They're going to need those medications. They may require supplemental O2. They may need suctioning or good pulmonary hygiene. They may get to the point where they need ventilator support. As well as when they're doing this, you're going to evaluate blood gas results to kind of tell you where exactly is your patient respiratory status wise. Comfort is always something that's very important to people who are having a hard time breathing because it does help improve gas exchange if you can get the patient to kind of relax. So using things like pressure relieving mattress pads, giving them, warm bath, massaging them, doing heat or cold to help, them just be comfortable, elevating the head of the bed. And that's true for anybody who's having any kind of respiratory distress. Elevating the head of the bed makes the work of breathing easier because it allows gravity to help the diaphragm do its job. And you also want to definitely pace their activities. They're not going to be able to go out and walk from here, 10 miles. They're going to only be able to go so far. So you need to pace those activities so that they don't become over exhausted or overworked respiratory wise. Pace activities, that's there again, and conserve energy. And then you may want to do active and passive range of motion, especially if they're on a ventilator. You're going to want to do some passive range of motion because you don't want them to get atrophies or contractures while on the ventilator. You're going to help them keep that range of motion and that mobility in the joints. Managing pain in patients with HIV. Some of the stuff is going to repeat from the last one. Pressure relieving mattress again, use of heat and cold, massage, using draw sheets for positioning changes. Drug therapies, they may use things like NSAIDs, so those non-steroidal anti-inflammatory drugs. They can use tricyclic and anticonvulsants for neuropathic pain, such as pregabalin. The SSRIs and SSNRIs can also be used for that as well, and they can also use opioids, but they are not usually the first line of therapy. Because we did talk about how sometimes these patients develop peripheral neuropathy, so they may try like the pregabalin or these SSRIs or the SSNRIs for that. And some complementary and alternative therapies would be things like acupuncture, massage, vitamins, herbal products, and shark cartilage even is something that they recommend. But keep in mind, if they're going to do herbal products, they need to be really careful. They need to make sure that whatever they're choosing does not interact with any of the medications that they're on. So being able to cross-reference that, they just need to check with their physician or the pharmacy. I would actually say pharmacy more than anything to make sure they're not going to take anything that is contraindicated with their antiretroviral regimen. Okay, now enhancing nutrition as far as, from a nursing standpoint, what do we do? Some drug therapies, they can do things like nystatin to help with some of the candidiasis and the mouth that's going on. I also think there are some medications that can be used to stimulate appetite. We use those with some of our oncology patients. So if they don't have much of an appetite, we can give them, sometimes we give steroids, sometimes we give a drug called Megace, I think it's called Magestrol is the generic for that, which helps to increase appetite. Some of these medications can also cause nausea and vomiting, and that may be part of the reason that they're having trouble with eating. And then we can also use antiemetics. Most people know Zofran or ondansetron. That's a good one to use for these patients as well. So nutrition therapy, you do want to monitor their weight and also their intake and output. You want to encourage them to eat high calorie and high protein. Always say get as much, the bang for the buck. Whatever you can pack into a small amount of food may be good for these people, especially if they're feeling anorexic and don't have much of an appetite. You do want to assess their preferences and also consider their cultural and religious practices when you're trying to develop a diet. And one thing I would also tell you, if you have access to a dietitian, definitely use their knowledge to help you develop a diet plan. Offer small, more frequent meals. This is something that I encourage anybody to do with somebody who's having issues with eating. It's so much easier. It's not overwhelming to the patient. It helps with nausea and vomiting and just with their overall wellness feeling if you will get them to eat small, more frequent. They may require TPN or some kind of supplemental vitamins to help maintain nutritional status. Mouth care is definitely something that's very important when you're trying to get somebody to eat. It does help improve their appetite if you can just get them to clean their mouth out before they eat, okay? So rinse with sodium bicarb, with sterile water or normal saline. Okay, so that's like a salt and a soda kind of rinse. And use a soft bristled toothbrush, especially if they have any tender or sore spots in there. Some complementary or alternative therapies are things like lemon juice, lemongrass infusions for thrush can also be helpful. Moving on to now managing diarrhea. So you can see it's on Iggy and page 340. So give anti-diarrheal medications on a schedule. So they may just need to routinely take them to keep those bowels from being too loose. Consult with your dietitian. Again, great resource because they may be able to offer foods that are less likely to cause diarrhea in the patient. Diets low in roughage, fat, spice, and sugar foods are what are recommended. You don't want them to drink alcohol, and you definitely don't want them to drink caffeine because it helps, stimulate peristalsis. Eliminating dairy may also help. Again, eating small, more frequent meals. Consume more fluids, especially between meals. Okay, not so much with the meal because you don't want them filling up if they're having trouble eating to begin with. So maybe not so much when they're eating as much as in between meals. Assess the perianal skin every 8 to 12 hours just to make sure if they're having lots and lots of diarrhea, you can start seeing breakdown of the skin down there, and then we've got a whole nother problem on our hands. So always wanting to assess that skin. And then also maintain good perianal care. Again, think about this. Diarrhea stool can be very acidic and caustic to the skin. These patients are at risk for infection anyway, so we don't want any skin breakdown because that's just another avenue for an infection. Restoring skin integrity, antiretrovirals, drugs, therapy, especially for people with Kaposi sarcoma, analgesics and comfort measures, and also appropriate skincare. So most of this stuff is things you should already know when you think of basic skincare. This is fundamental stuff. Just consider those nursing interventions. So helping to minimize confusion, you definitely want to use reorientation techniques. So you want to keep them oriented to person, place, and time. Keep items in the room that are consistent so they're familiar to them. Sometimes they talk about having something as simple as a calendar in there with a clock can also be something to help them stay oriented to time. Give simple, short instructions. So don't go listing off, I need you to walk over to the other side of the room, pick up the crayon, move it over to the cup, put it over here. Give it one thing at a time. I need you to walk over to this side of the room. When they do that, I need you to pick up the crayon. Something that's simple like that. Some drug therapies, they may require psychotropic meds to manage their behavioral or emotional issues. You always want to make the environment safe and comfortable for the patient, and you may also need to institute seizure precautions if they start having mentation problems or they have things going on in the brain like encephalopathy that could increase the risk of seizure activity. Always want to provide support to the patient as well as the family. It's very scary, especially if the patient's not ever been confused and then they suddenly start having confusion issues because we have activities going on in the brain, or if the liver is starting to fail. Just I can think of a lot of different reasons why the patient might get confused, or infection for that matter can do it. It's very scary for the family as well. And answer questions honestly, but always be sensitive in how you answer it. You know, yeah, you're going to die. Not really the best way to answer that question. So just think about your words. You want to be honest, but you also want to be sensitive in how you deliver it. Finally, looking at supporting their self-esteem. HIV is one of those diseases that still have somewhat of a stigma around it as to how did you get it. You know, sometimes it just takes being at the wrong place at the wrong time, and that's all you've done. But unfortunately, like I said, when this disease first started, there was so much just negative thought that went with it. And there was this idea that if you got it, you somehow deserved it because you were being bad. And I mean, it was so sad, so sad. I can't even put enough emphasis on how bad it was back in those times when this first started. But there's still, for some people, they still remember that time. And this can be something that hits them very hard from a self-esteem aspect. So you always want to provide a climate that is accepting of them. You want to promote that trusting relationship. They know that you are a safe place for them. Encourage them to talk about what they're thinking, what they're feeling. Allow them to express that to you. Identify positive aspects that you see in them, but still give them some privacy, but don't let them completely isolate. And that's sometimes what they may want to do. And for some people, it's maybe because they're not well educated and they think they are infectious and they do think they can spread it to other people just simply by being in the room with them. So educating them on that. Encourage them to do as much of the care as they can do. You want them to be independent. You want them to feel like they have some sense of control of what's going on in their life, because for some people, hearing those words, they instantly think I'm going to die and everything spins out of control for them. So giving them those opportunities to have some kind of control about their day is very helpful. And then guided imagery, which I think is actually a really wonderful tool for patients. You know, if things are feeling a little overwhelming, they can just close their eyes and maybe go somewhere else that's happy for them. That gives them a little mental break and allows them to kind of reset themselves. So these are just some things. We don't ever want to forget the psychosocial impacts of diseases on patients. I know we tend to get really focused on the physical needs, but we also need to understand that mental health and the psychosocial aspects have a very deep impact on the overall well-being of our patients. Now we're going to talk about some care coordination and transition of management, and this can be found in your Iggy book on pages 340 to 342. So some home care management things they may need help with ADLs around the clock and nursing care, especially once they've transitioned over to AIDS. They may need help with drug therapy and nutrition support for those who are severely ill. Like I say, they may have a feeding tube placed, so maybe they need help, they need educated on how to do that, or they may not be able to actually do it for themselves. Teaching self-care management, some modes of transmission, infection prevention, and again about medication therapy. So there is a great box in here on page 341 that talks about management, patient and family education, preparing for self-management. So good little box on page 341 that goes over a lot of the things that the families may face. Psychosocial preparation, already talked a lot about fear and social stigma, and the patient may feel that they're going to be rejected if people find out that they have HIV or treat them like they, are a leper and are the scourge of society and need to go away. Offer support and referral to community resources, as well as additional healthcare resources. So they may require home health, and it may not be for too terribly long, but they may need home health services. They may have issues getting food, so Meals on Wheels. Transportation, that could be to go to their doctor's appointments, and community and mental health or behavioral health resources as well. Like I say, we need to remember that we give holistic care, so we have to treat the whole patient, not just a part of them. Okay, so looking at some of the legal and ethical tenets of patients with HIV, what kind of things do you think of could possibly come up from a legal standpoint regarding their care? And I've kind of got these kind of things here, like end of life decisions, some of the discrimination issues. I can tell you when this first started, that was a problem because some nurses refused to take care of them because they were afraid they would actually contract it before we became better educated. So there are some legal issues that come up. Ethical and cultural, all these things, end of life is going to become a potential issue for them. And I think of some of the ethical and legal, again, thinking back to when this started, and a large population at first who contracted this disease were homosexual males. Now, this is back in the 80s, so some of these people were alienated from their families when they made the decision to come out. And so their partner became their family. But legally, they were given no rights to make any kind of choices for the family member, which is really kind of sad because it was probably that was the person they shared their wishes with more so than maybe their family, because their family had disowned them. And so that became an issue too in the care for these patients. If you've ever seen the movie, if you have not, there's a movie called Philadelphia, and it kind of dealt with a lot of those particular things. It's a great movie with Tom Hanks and Denzel Washington. And I think it's also got Antonio Banderas, if I remember correctly. It's a wonderful movie that just kind of gives you an idea of what it was like for people living with HIV when this disease first started. And it's really quite sad how they were treated. And then also culturally, again, end of life, but also religious views revolving around homosexuality, because some people believe that's the only way you get it. And that's not true. Somebody could have got it through, unfortunately, a tainted blood transfusion, although very, very rare. Or they could have had sex with somebody that was bisexual and they did not know, or had sex with somebody who, just unfortunately it was just the wrong time, wrong place kind of thing, had heterosexual activity and still contracted it through that type of sexual contact. So there's a lot of things legally and ethical and culturally that there are a lot of myths that need to be dispelled, and I feel like part of our job as nurses is to educate people that what they believe may not always be how it really is from a medical standpoint. We're just going to look real briefly at some of these other immune deficiencies. So there's a congenital or primary immune deficiency. This is something that is very rare. It's a defect in the development or function of one of the or more of the immune components. And there's really no adequate protection for this patient from cancer or from infection. Then you also have selective immunoglobulin A deficiency. Kind of talked about this a little bit when we were in the class with Megan. It is the most common congenital immune deficiency. They are very prone to respiratory, GI, and urogenital bacterial infections. And then these are the ones where I told you if they have this selective immunoglobulin A deficiency, never give them IVIG. Because it will cause a very severe allergic reaction. So these patients do not receive the IVIG like you might see with some of the other immune deficiencies. So some treatment that's used to treat some of these other immune deficiencies are antibiotics if they were to develop a specific infection, long-term prophylactic antibiotic therapy for people who are at high risk. And then IVIG may also be given for some of those, and they've got some here, this Bruton's agammaglobulinemia or hypogammaglobulinemia. They may choose to use this IVIG, but we do not use IVIG, and when I say that, that just stands for intravenous immunoglobulin. We do not do this with the people who have that selective immunoglobulin A deficiency. It's just, if I want you to know anything out of here, it's just deficiency in IgA, we don't give IVIG. Switch gears again and start talking about transplant rejection. So normally in the body, we have these natural killer cells and cytotoxic, these cytolytic T cells that destroy things from other animals through cell-mediated immunity. That's what they're supposed to do. And usually it's helpful, but it's also responsible for rejection of tissue grafts or transplanted organs. You know, the immune system is just doing what it says. We've talked about this a lot, self versus non-self, okay? The body knows what's supposed to be there, and it does its best to protect all the things that are there. So when something foreign comes in, the immune system kicks off this process to protect itself. And that's what happens because the organ is recognized as not being of itself, okay? Without intervention, the immune system starts this inflammatory and this immunological process that will eventually destroy the things that were not originally in the body or non-self cells. So that's what happens when somebody has transplant rejection. The things that are there normally to protect us are not necessarily what we want when we're going to introduce somebody else's organ into our body. Okay, so now we're going to talk a little bit about the rejection processes that occur in transplant. Talked about these a little bit in class with Megan. It's important for you guys to understand the difference between a hyperacute reaction versus an acute reaction versus a chronic reaction. Hyperacute, that begins really quickly within that first 48 hours of surgery. There is widespread clotting that occurs, which then leads to necrosis because that tissue is not being perfused, which then leads to massive cellular destruction. And the only thing you can do for this is remove the organ. You cannot save it. It just has to come out. You don't have a choice. This does not happen as often now due to this HLA matching, which is the human leukocyte antigen matching. And we do this with blood too, especially in patients who have lots and lots and lots of blood transfusions. They really require a lot of HLA matching. And so what it used to be is like when we would do this, the first thing they always look at is what blood type. You know, if the person's A positive, they need to receive an A positive blood type person's kidneys. But now we take it much more further. And there was some other testing, but now that we do this HLA matching, it really matches the different antigens, which are responsible for like the body going, hey, whoa, you're not supposed to be here. So if you can get all those antigens matched closely, the risk of a hyperacute reaction is significantly lower because they're just not present because they all match. Acute rejection, this occurs within 1 to 3 months. It's similar to above in what happens, but the natural killer cells enter and also affect the destruction of the tissue. So it's not as rapid kind of thing. Manifestations will vary with the person and the organ. It just depends on what organ you transplanted. So if I'm transplanted a kidney and I have an acute rejection, eventually I'm going to start to see signs and symptoms of renal failure. If it's a liver, it's going to be liver failure. Okay, lungs, the lungs are not going to start working as well. In chronic rejection, the tissue is usually replaced with fibrotic or scar-like tissue. And if you think about it, it's because you have a lot of inflammatory processes going on, which can cause that scar-like and fibrotic tissue to occur, and it eventually will lead to the failure and the need for another transplant. And sometimes you'll see that. You'll see people who have had, a kidney transplant, and 10, 15, 20 years down the road, they start having this chronic rejection problem, and they eventually have to have a new organ replaced. So moving a little further, what do we do about it when we have somebody who has transplant rejection? So management of the rejection is designed to sustain the life of the new organ when possible. Keep in mind, if it is that hyperacute, I'm not saving it. The only thing I can do is immediately remove it and try to get another one, okay? And try to maintain, if I can, the function of the organ, okay? I may not be able to do that, but that's kind of the premise of it. With an acute or chronic, they're going to do some of these immunosuppressive type therapies, okay? So like with a hyperacute, they're going to increase the doses of those immunosuppressive drugs, trying to keep the body from rejecting the organ. Hyperacute, take it out. Acute, increase immunosuppressive therapy. These things are taken for life. They do risk or increase the risk that they can develop other cancers and bacterial or fungal infections because they weaken the immune system. Like I say, the immune system is very important, not just in protecting you from infections, whether those are viral, bacterial, or fungal, but it also plays a significant role in the stopping cancer development. So those patients will be at increased risk for developments of things like that. Rescue therapy is used to treat acute rejections, like I just said. It may use the same as for maintenance, but it is just higher doses. Kind of already talked about that. They're already on something. Now we're going to increase it when they start an acute rejection process. They may also use monoclonal or polyclonal antibodies to some of those MABs. And this is the page where I told you to refer to with the table. It kind of gives you kind of a quick little view in a really small amount of space. So a good little table to take a look at. Okay, now we're going to move on to the next thing, which is an oncological emergency. That's how it was written in the syllabus, but sepsis or septic shock in general. This does not just occur in oncological patients. Okay, people can get sepsis from other infections and develop septic shock. So I've given you the IGI chapter. It's just part of it because it's actually in the cardiovascular, has to do with tissue perfusion, where they go over all the different types of shock, but the one I want you to focus in is on septic shock, which is on page 740 to 746, as well as in your ATI medical surgical book on chapter 37, also covers sepsis and septic shock. Okay, so this slide kind of has it in a little like algorithm chart all the way down, and then there's some, information to the left there that kind of talks. So basically it's a local infection or any problem that impairs, that starts out, and what happens is it's just a problem that impairs oxygen delivery to the tissues and the organs. This is what precipitates the shock. You have widespread abnormal cellular metabolism, and eventually the tissues do not get enough oxygen. Those needs are not being met. They have this inflammatory response. Eventually the organs start to fail with severe sepsis, and they go into this multi-system or multi-organ system failure, or MODS, and that is septic shock. And unfortunately, this can lead to death. Okay, this is a life-threatening emergency. That's why it's so important that you understand how you treat it, how you recognize it, because if you can step in before this person gets down to where they're getting into severe sepsis and septic shock, we have a chance to turn them around. Once they kind of turn that corner and go to that lower part of this algorithm or this little chart, it's really hard to bring the patient back from that. And unfortunately, mortality rate is quite high once they hit that point. Let's just kind of reiterate what was on that previous slide. It's a complex type of chemical-induced distributive shock. That's what septic shock is. It is a form of distributive shock. Bacterial and fungal infections progress to dangerous conditions within days. And for some people who are immunocompromised, it will be hours instead of days. Sepsis is widespread infection that is coupled with a systemic inflammatory response, or this SIRS, which is triggered when infection escapes the local control. So it gets past the local spot. It's now in the systemic part of the body. It gets taken up by the blood, and now they become septic or sepsis, okay? Septic shock is associated with a systemic inflammatory response and sepsis with multiple organ dysfunction syndrome or MODS. And early detection, like I said before, is key to keeping it from progressing to the point where the patient is actually in septic shock. And that's why it is so important that when we are taking care of patients, we are monitoring those vital signs. You know, what do you see in a patient who has an infection who is starting to go downhill? You might see an increased temperature. You may see an increase in heart rate. Their blood pressure actually can go down, but it could also come back up and then go back down. So that's kind of one of those that goes everywhere. Same thing with respiratory pattern. Depending on what's going on, the respirations may change. A lot of times they go up in the early stages because they're trying to help itself. It's kind of a compensatory mechanism. But learning to recognize those things and intervene, that's why we monitor lab. That's why it's important. If I see my patient's white count doubled in one day and they're currently on an antibiotic, that's concerning to me. I'm going to be notifying my physician, and I'm going to be watching them for changes to make sure they're not starting into this cascade or this, algorithm of sepsis and septic shock. We look at this multiple organ dysfunction syndrome. This is a sequence of cell damage caused by massive release of toxic metabolites and enzymes. Okay, this is a priority problem. It makes sense if all my organs are failing, that's going to be a problem. Okay, it's not just my heart, my kidney, or I should say, it could be your liver, it could be your kidneys, all those things. You have to remember all these systems are going to be affected. It is a priority problem. Microthrombi form, and when I think of this, these are the patients that typically start going into DIC. That's why they get to this problem. And DIC is that process, that disseminated intravascular coagulation, where the body starts using up all its clotting factors by making all these teeny tiny little microemboli or microthrombi, and they're going scattering throughout the body. And that's one of the reasons they start into this multiple organ dysfunction syndrome, is because they're getting all these little clots in these organs. And then eventually what happens is they've used up all their clotting factors and then they start bleeding. So again, review under hypovolemic shock. This whole process is there on page 744. This is just a little kind of graph showing you again, little like flow chart to show you the processes for MODS. So this, for some people, this makes more sense to them. So I included this for you guys to review. So failure to recognize, I've been harping on you guys for this. Last semester I did, and I'm going to continue. Failure to recognize and intervene in early sepsis is a major factor for progression to septic shock and death. And like I said, once they turn that one corner, it is really hard to bring them back. And death rates for patients who progress to actual full-blown septic shock, it exceeds 60%. So over 60% of the people, if they're allowed to go past that point of just having sepsis and not septic shock, will not recover. So that's why I say it's very important for us as nurses to recognize those clinical manifestations or signs and symptoms, whatever you want to call them, to make quick determinations of when our patients are getting in trouble so that they don't progress to this point. We're going to talk a little bit about some of the assessment tools used for sepsis. And the sequential organ failure assessment, or SOFA, was something that was devised by a task force that was developed to help with recognition and to create a tool that can be utilized by nurses. So you have quick SOFA, or this Q SOFA, which you can see down below. This is typically used in your non-invasive. I see that I just misspelled that, care settings. And then SOFA is used more in your critical care settings. So these are just some quick little things you can look to try to make a rapid assessment of your patient to determine the risk of the development of sepsis. Okay, so the quick SOFA has got systolic blood pressure less than 100, respiratory rate greater than 22, and any changes in mental status. So that's just a rapid thing that you can do if you see that that should be an alert to you that, hey, my patient may be becoming septic. And in the SOFA, you have a respiratory, you look at the PaO2 and that FiO2. You look at coagulation, things like, are the platelets less than 100? Liver, bilirubin greater than 2. Cardiovascular, you have hypotension that requires vasopressor support. Central nervous system, you have a Glasgow Coma scale less than 12. And then also you're looking at the renal function, assessing that creatinine. Is it greater than 2, or is urine output less than 500 milliliters per day? Now, just kind of keep in mind, these are used for rapid assessment kind of things. So these are just some of the ones your book has used. And this is actually in your book on page 742. There's a little table that kind of goes over, explains it a little more in detail. So if you want to look at that, you can. The system that's used is called this Modified Early Warning System, or MUSE. So you may hear this term used. I heard this term up at Freeman used. Again, this is in your book in IGGI. It was developed to identify hospital patients who are at risk for the clinical deterioration or development of sepsis or going into septic shock. It does incorporate a lot of the things that you saw in that Q SOFA. In addition to, it looks at heart rate and temperature. And like I said, that Q SOFA was the one that looked like the respiratory rate, looked at your systolic blood pressure and mental status changes. Okay, so screening tools, they're good assessment things that we can use. They do lead to early detection, which hopefully, like I said, that will alter how the patient will do. We want to change the prognosis so that our patients are caught quicker than before they're actually going into full-blown severe sepsis or septic shock. Okay, so what do you see in these patients? What are those clinical manifestations you might see in patients who have sepsis or going down this path? So cardiovascular-wise, you're going to see cardiac output and blood pressure lower in the early sepsis and septic shock phases. The blood pressure will increase as they convert over to severe sepsis despite the worsening condition. And that's where it gets tricky, because you're treating these patients who have drop in blood pressure and it comes up and you think they're getting better, which they may not be. They actually may be getting worse. They may actually be going from sepsis to severe sepsis with that increase of blood pressure. And that just has to do with the body's compensatory mechanisms kind of allowing it to recover for a little bit, but then it wears out again. And DIC develops as the condition worsens. And again, DIC is the one where they use up other clotting factors. Respiratory rate will increase. Depth will also increase with tissue hypoxia, and acidosis, which makes sense if you think about that. When we talked about respiratory acidosis, we know the patient's respiratory rate is going to increase because it's trying to blow off CO2. So it's doing what it's supposed to. It's trying to compensate. Unfortunately, with sepsis, eventually they're not going to be able to. ARDS may develop, or that acute respiratory distress syndrome or adult respiratory distress syndrome may develop. This couples with septic shock as a highly mortality rate problem. We're trying to avoid the development of ARDS. We're trying to try to keep them from going into MODS. So when they go into ARDS with sepsis, it is not a good sign. I mean, those patients very rarely survive at that point. Skin-wise, with progression, they will become cool, clammy. They'll be kind of pale in color. You may see mottling or cyanosis. If DIC occurs, you'll see that petechiae, those little pinpoint rashes, as well as ecchymosis or bruising on the body. You can also see oozing or bleeding from the gums, any kind of venipuncture sites, or in the mucous membranes. Basically, when they go into DIC, because they use all that clotting factor up at the beginning, where they're showering all those little microemboli everywhere, they don't have any available. So then any place that they have available to bleed, they can bleed from. It's kind of, I hate to say it's kind of creepy looking, because they're literally just oozing blood from any hole that's in their body. So continuing on with some of your clinical manifestations, with your renal and urinary system, you're going to see a decreased urine output, which makes sense because our kidneys are probably not getting perfused because the body is going into a shock kind of situation. So blood is going to be shunted to the most important places, and the kidneys usually get left out. So you'll see the urine output start to go down, and if you're looking at labs, you'll also see that serum creatinine go up as those kidneys are losing their ability to function. Psychosocial assessment changes in affect or in their behavior, so they may start to become confused. Hallmark sign of with laboratory test is increasing serum procalcitonin and lactate levels, a normal or low white blood cell count. It could be high as well, and a decreasing segmented neutrophil level with a rising band neutrophil level or a left shift. So I would kind of, you know, when you think of this, that's why they draw that lactate level. That's why they get a procalcitonin oftentimes. They're always going to get that CBC, so you're going to look to see if there's that shift. Again, I think sometimes we always think that the white count will be high, but sometimes it won't be in sepsis. So keep that in mind. Just because the white count comes back normal, that they can't be septic, because they can. Okay, same thing if it's low, they can still be septic. So that's why you get these serum lactate and the serum procalcitonin levels drawn on those patients, which if we think about the 1 hour bundle, that's why we do that. Some additional or some other laboratory assessments that you're going to look at with septic shock, kind of like I already got the hallmark there again, but I don't see the procalcitonin listed, though it should be. CBC, you're going to get blood cultures. You're going to try to get those cultures. You want those cultures drawn before you start that first antibiotic. They may do look at activated protein, or they can call this a C-reactive protein. Sometimes they call that. Other biological indicators of severe sepsis or septic shock are things like they do a plasma D-dimer, and that's oftentimes looking at DIC when they're doing that. Same thing with cytokines and interleukin levels. So that may be some other lab that they do. What I'm more interested in that you guys understand is that 1 hour care bundle talks about the lactate or lactic acid level and the CBC. But do know that they will probably do some of these others if they're worried about severe sepsis or septic shock with the D-dimer and stuff like that, to make sure they're not doing or already in DIC. Okay, so what do we do to take care of these people? They may require, or they will require, oxygen therapy. So use the method that will deliver the optimal O2. So if you can just get by with a nasal cannula, especially in the beginning, use the nasal cannula. If you have to go to high flow, you go to high flow. But these patients may also require mechanical ventilation to take over for them and correct acidosis and that kind of stuff. Drug therapy, they're definitely going to need some kind of IV antibiotics. They may need corticosteroids if they have adrenal insufficiency. They may need insulin if they have elevated glucose levels, because keep in mind, especially in your diabetics, they get a severe infection, they're probably also going to have issues with glucose control. Heparin for clients who have that microvascular abnormality and have small clots. And that's kind of where it's weird with DIC. When they first start, you oftentimes have to give them heparin for all those little microemboli that they have created. And then you have to turn around and give them blood transfusions and things like that when they start bleeding. So they may do blood transfusion, they may do clotting factors, platelets, FFP, or that fresh flows in plasma, as well as those packed red blood cells. I have referred you to table 34.5, that bundle for resuscitation and management of care for sepsis. It's a little purple box in the very corner, and it has a lot of good information. I would strongly suggest you review that. Hint, hint. And this is what that little box in the corner of page 745 looks like. It's that 1 hour care bundle, or within 1 hour, what they want you to have done is measured that serum lactate level. So you've drawn that blood and you've obtained that number. You obtain your blood cultures before administering your antibiotics. You administer a broad spectrum antibiotic. You begin rapid administration of crystalloid fluids for hypotension or for lactate levels above 4 millimoles per liter. Okay, a crystalloid would be something like normal saline or LR. Usually they use normal saline. You will apply vasopressors if hypotensive during or after the fluid resuscitation to maintain a mean arterial pressure of 65 millimeters of mercury. So if you're giving that fluid, you're giving that bolus of fluid and it's not helping, you add the vasopressor. And you do that because if that pressure is too low, you are going to run the risk that you're going to have an acute kidney injury. So you want to maintain that mean arterial pressure, or that MAP, above 65 millimeters of mercury. So, care coordination and transition management. This is where you're getting them ready to go home, that kind of stuff. You're going to evaluate the home environment for infections or hazards to them. And there is a box in IGGI. Again, I've given you the page number there. Self-management, education. You know, you're to teach them about hand hygiene, washing, hygiene in general, balanced diet, rest and exercise, taking care of their skin, good mouth care. All those things you would do it's kind of like portals of entry for infection, that's for skin and mouth and that kind of stuff. Teaching them the balance of resting, not becoming too exhausted. Good diet to help maintain good immune function, okay? Teach them how to take a temperature or read a temperature. Believe it or not, there are some people who do not know how to do that, so you may need to teach them. And also contacting their healthcare provider if they get sick and have infection again, especially people who are immunocompromised. You definitely want them to understand the need to reach out. And I think back to some people I've taken care of that had septic, went into sepsis, and it started from a wound on their skin. They thought they could take care of it at home. They tried to drain the abscess themselves, only making it 10 times worse. And I'm sure if you watch TikTok or any kind of videos online nowadays, you can sit there and spend your whole day watching people trying to drain their own abscesses that are red, swollen. You can tell they are probably warm to the touch. And all you're thinking is, please don't do that, and please get a hold of the doctor, because these are the patients you're going to see come in and are septic. So teaching them good practice, instead of like, don't shoot another TikTok video because you want to be famous. Go to the doctor and let him do it because he's trained. So just providing good education for patients. Okay, so the next slides, I think there's like 4-5 slides here that are a case study. I'm not going to go over this. If you want to do the case study on your own, that's perfectly fine. The rationales for all the answers are listed below. This is just a little practice for you to, you know, work through a case study with a patient who has HIV. So if you want to do that, I encourage you to do it. It's a great way to study. And then the final 2 slides in this presentation really just have to do with outside resources. So I've listed the different Khan Academy videos that you can find on YouTube. I particularly love these. These are probably some of my favorite Khan Academy videos, are the ones on HIV. They really helped me to understand the virus probably more than anything else I've ever watched. The next slide, I know Nurse Sarah does a video on HIV too. It's longer. I know some of you like Kathy, and I don't have a problem with Kathy, and I cannot think of the gentleman's name with Simple Nursing. They both have, you know, some good videos with HIV, but I really love Nurse Sarah's video on HIV. Again, she does a really good job of explaining the whole process, but it is a little bit longer. And then there's also some videos on sepsis, septic shock, some stages of shock. So there's just some other videos that I've listed from both, I shouldn't say both, from Khan Academy, from Registered Nurse RN, Level Up RN, and also Simple Nursing. So if you want additional resources and you find videos helpful, I would encourage you to take a look at some of those.